Hi, Mike and Matt. This is Jack Nicholson. Long-time listener, first-time caller. Can you please discuss this new lung ultrasound article from The Lancet? I don't know what to think about it. Does lung ultrasound really mean quicker, more accurate diagnosis? Or does it lead to more testing without much benefit? Please help your old friend, Jack.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
As you may have guessed, we get calls from Jack like this all the time. This was different though, because others were talking about this paper. People like Ryan Radesky, Simon Carley, Rory Spiegel, Cliff Reed, and others. People just as smart, cool, and raspy as Jack. So we went straight to the source and got the author of the paper, Christian Larson, to do a hangout with us. But not just us. The lung queen, Vicky Noble, whose idea it was. The lung prince, Andrew Leteplo. Sorry, Andrew, but I can't afford to have Liechtenstein coming after me. And some other smart folks from Harvard and Kentucky. So without further ado, and Jack, we'll put up part 2 in just a few days. No need to call or email.
Welcome, everybody, on our first International Journal Club. It's very exciting. And we are really thrilled to have Dr. Larson here to talk about his article. A lot of us have been really excited about the potential and the possibilities with lung ultrasound, but obviously whenever there's a new technology, we have to learn how to use it smartly and learn how to use it efficiently. And so I think Dr. Larson's article is one of the first to kind of approach that in a really scientific way. So basically what he did was he took patients who presented to the emergency department with chest pain, dyspnea, and or cough, and they had to have a few other inclusion criteria. They had to have a high respiratory rate, so respiratory rate greater than 20, an oxygen sat less than 95%, or to have been started on oxygen. And the idea here is to get the, not the mildly dyspneic people, but the more acutely dyspneic people as the kind of in the inclusion criteria. And then what they did was they randomized people, 160 about in each group, to either get an ultrasound protocol done by an expert, who was actually Dr. Larson himself, within the first hour of presentation. And there was kind of a very standard protocol, which actually is a Danish protocol that Dr. Sloth has used for his patients being admitted to the ICU in Denmark. And it looks at the heart, it looks at the lungs, and then it also looks at the venous system. And that had to be done within the first hour. So it was sort of a convenience sample in that, Dr. Larson had to be available and had to be able to do the protocol within the first hour. And then what they looked at was the percentage of patients who had a quote-unquote correct diagnosis within 4 hours. And that correct diagnosis was decided by 2 people who were not involved with the case, reviewing the chart and deciding on the diagnosis after the fact. And then also looking at the initiation of correct treatment and diagnostic testing, length of stay, some other kind of metrics in terms of outcomes. The kappa between the 2 doctors who were deciding the correct diagnosis, I think was 0.7 or 0.8, so it was good. And that's a very standard way to do these kinds of gold standards when you don't really have another way to measure what the correct diagnosis was. So this is his flow diagram from the paper. There were 788 patients assessed for eligibility. 320 were randomly assigned. Andrew had a question.
For those of you that have been sleeping for the last 6 years, that's the voice of Andrew Leteplo. Maybe the biggest and one of the most challenging last names to pronounce ever. Lightplow, Let It Plow, Leteplo is too much for me, but the man is a relative ultrasound genius, and maybe the best lung ultrasonographer I have ever debated at an SAM conference in Atlanta on the utility of lung ultrasound for the diagnosis of pneumothorax. What masterful question do you have for us now, Andrew?
Can you just quickly go over what your actual protocol was, specifically with the lungs? Because there are so many different ways to do lung ultrasound. I'm curious, I didn't get a chance to see the appendix, so you just
sure.
What we look at and how many things, what you call positive, etc.
Actually, the protocol we did was, as Vicky told, the heart protocol we used were the one described by Eric Sloth. It's just a FATE protocol, which basically is 3 heart views, the subcostal, apical forechamber, and then pars-donor view. What we did then was the focused lung examination. We did the 4 anterior zones and only two anterior zones on each side, 2 lateral zones, and then 3 posterior zones when we scanned. So it was a bit of a combination of what has previously been described by Walter Pacelli and then joined by something Lichtenstein has described in one of his books. So and the reason why we chose those were because we wanted to be able to fit in the international definition for interstitial syndrome, which uses 4 zones on the anterior and lateral side of the chest. And then we also wanted to be able to assess the posterior part of the chest, because pneumonia and pleural effusion would probably most often be seen there. And then again, we had to take a decision on, we didn't want to use too much time on the lung examination, and on the other hand, we didn't want to miss any minor consolidations. So the pragmatic solution was this zone principles, in which we then joined what has been described by Walter Pacelli and Lichtenstein.
And you did a DVT study as well?
Yeah, then the DVT was such a 2-point assessment of the deep veins, which has also been described by your guys. So merely from the protocol prescribed by the American College of Emergency Physicians. So that was what we done for the DVT examination, and both legs were examined, no matter whether they had any complaints or not.
And that's the other thing that's important, is that the ultrasound protocol was applied the same to all patients.
Yeah, it was.
Yeah. The other thing I was going to say is that because of the way you guys did your randomization, you've gotten some attention for it, because they basically allowed the patients to pick the envelope and then open the envelope and find out what their randomization was, which I thought was very democratic and very inclusive of you. So good job. Okay. So as you can see, the randomization as selected by the patients themselves worked quite well, and this is in the paper, but all the kind of things that you would hope are pretty equivalent in the 2 groups, so I won't go through this in a lot of detail. So basically, again, they looked at the gold standard was the 2 blinded reviewers of the chart, and they had a good kappa, so that's obviously reassuring. And the main outcomes of the paper were that both the correct diagnosis and the correct treatment were much higher in the POCUS group. So at 4 hours, 88% of the people who had the ultrasound protocol applied had the correct diagnosis, versus 63% in the non-ultrasound group. And at 4 hours, 80%, 77.9% had the correct treatment initiated with POCUS, versus 56% in the control group. So, sort of explaining what we all kind of know intuitively as ultrasound people, is that you get the diagnosis faster and you can make decisions about treatment more effectively. So this was a really a good outcome, I think, and supports what we all kind of know about point-of-care ultrasound. Again, there was another outcome they looked at, where they asked the physicians themselves whether this added new information or whether it added new information with the change in treatment. And you can see that about 41% of the physicians who were had these patients as the primary care people, they said that 41% this added new information, but it didn't really change their treatment, which is maybe useful but not so important. But 36% of the people said it added decisive information with changes in treatment, and so that's obviously a huge difference, and very impressive in terms of what POCUS had to add. I think what has gotten a lot of attention here in the States, and at least on all the Twitter blog people spheres or whatever, is that this chart, which shows that when you look at the supplementary diagnostic testing that was done 4 hours after admission to the emergency department, if you look at all of these on the left, the CT of the chest, echocardiography by a cardiologist, a VQ scan is what we call it here in the States, diagnostic fluorocentesis, all of those are shifted to the left in favor of the ultrasound group. And so I think what some people have thought was that if you do ultrasound, all you're doing is you're increasing the amount of testing and the amount of procedures that are done because you're finding things. However, I think that's a little bit of a misread of the paper, because if you look then at the entire hospital stay, and you look at the number of tests and procedures that were done during the entire hospital stay, that's not clinically significant. And so the way I read this, when I read the paper, was that it's not increasing the amount of testing that's done, it's just phase shifting that testing earlier in the stay so that people are getting all these tests earlier. They're getting a CT earlier or a thoracentesis earlier or that kind of testing done because you know what the diagnosis is, and so you're initiating treatment earlier. Unfortunately, however, this does not translate into what I would hope, because you would imagine that if people are getting all their testing phase shifted earlier in their stay, you would hope then that some of the other outcomes that we look at, such as hospital-free days or length of stay overall, or even mortality, these things you would hope would be improved by doing a whole bunch of testing earlier in your hospital stay. And unfortunately, again, the study was not powered to look at this, so it's a little unfair to put this on the study itself, but they were essentially the same. So again, that also has gotten some attention. I think it's a little bit unfair to judge this particular study because it wasn't powered to look at these outcomes, but it's certainly interesting and thought-provoking because I think most of us, whether it's ultrasound or not, think that if you do things earlier, people end up doing better. So that was a little bit surprising. So again, not powered to see those outcomes, but still I think it's thought-provoking and definitely something we should think about as the point-of-care community. The other thing I think that's a little tricky is, of course, Dr. Larson himself is a very expert, trained
very
sonographer, and so if you can get Dr. Larson to come to your emergency department in 1 hour to do this protocol, you will add value to your diagnostic accuracy. But obviously, we need to apply this to everybody, and if everyone uses the same protocol with kind of a variety of experience in testing, will we have the same outcomes? And I think we don't know that yet. I think the other question is, does earlier testing and initiation of treatment, why is it not impacting outcomes? And actually, Mike Stone and I talked about this a little bit earlier this morning, and his thought on this was that while Dr. Larson and perhaps the people in the emergency department believe the point-of-care ultrasound, it's not entirely clear, and this is at least true in the United States, that all the upstairs teams and consultants and everyone else believes point-of-care ultrasound. So maybe they're just continuing to practice as standard of care, not using that point-of-care information in their decision-making. But that's just a hypothesis. And then again, the length of stay, mortality, and hospital-free days were not impacted. But I think that is, again, it wasn't powered to see that. So I think, the next question is whether we could make this something. We always talk about here at Mass General, we always talk about Tim in Plattsburgh, which is like the everyman of ultrasound or of emergency medicine. So if Tim in Plattsburgh, New York, reads this article and starts doing this, then you've really made a difference because he's just a regular guy, seeing patients on a regular day.
Ultrasound Podcast does not support or condone the derogatory nature of these comments towards Tim.
And so if we can get Tim in Plattsburgh to do this, and he can make the diagnosis earlier, and he can initiate treatment earlier, then I think we've really done something. I think we still need to think about the outcomes and in terms of what we're looking at. But anyway, Christian, I would be interested in your thoughts about that, and if you want to just say a few things about what we talked about when we were in Denmark.
Yeah, sure, no problem. I think I'll just mention some of the points which you've already mentioned, Vicky. To begin at the top, because if we start with the inclusion criteria, if I had looked at some of the other studies of point-of-care sonography, is that typically in many diagnostic studies you choose a relatively well-defined patient population and include them. But in my opinion, the way definitely I used sonography was in patients just getting admitted with respiratory symptoms, and we tried to also make that influence our inclusion criteria because we use chest X-ray in a wide area of patients. So rather than choosing a small, well-defined patient population, we wanted to have a relatively different patient population with many different diagnoses, so that the patients we included looked like the everyday patient coming into the ED with dyspnea. So that was basically the reason why we chose those inclusion criteria. Then you said something that, of course, that's up to debate, where if you only take one expert doing this protocol, definitely in the study, it was a pragmatic choice, because in my department, when we began the study, there was no other who could actually perform the examinations. So if we had to do a randomized trial in order to find out whether this worked or not, then we would have to educate 10 physicians before we could do the study, and that would mean more hours, more education, and also resources. And the department wouldn't definitely throw any resources after us for a thing that, well, they basically didn't know whether it worked or not. And I think what's a point could be, if you look at other studies where you try to evaluate diagnostics and treatment, then you wouldn't set people to do it who are not experts. If you, for example, take a cardiologist doing a study of coronary intervention, they wouldn't take the everyday cardiologist and then publish the results on that. Then they would begin with an expert and find out whether this works, and if it works, then they would try to implement the results. So that was the background for doing that, because I could be fear if I just had taken some of my colleagues who were not properly educated and then did an RCT, then the results might have proven that point-of-care sonography didn't work. And didn't it work because I didn't educate the physician good enough, or didn't it just work because it didn't work, so to speak? So in a manner which were pragmatically possible, and also would be able to find out whether systematic ultrasonography actually worked, this was how we chose to do it. And of course, there also has its limitations, but that's the way it is. So, and I know, as you will probably also do, if I get 3 of my colleagues to do an examination of the heart and lungs and so on, then the protocol would vary a bit from patient to patient, and probably not be as systematic in all 160 patients. So this was also a means to ensure that all patients got the same sonographic examination, no matter what. You talked a bit about the protocol we chose with the heart, the lung, and the DVT. And if you look at the diagnosis which we found, basically you can say that the heart contributes with a lot, and also examination of the lung also contributes with a lot. Whether all patients should be examined with deep venous assessment can be questioned, because I think it was only around 2% of the patients in which a DVT could actually be identified. So the impact of doing deep venous assessment is probably not that big. So in the pragmatic world, you should probably not scan the deep veins of all patients getting admitted with respiratory symptoms, but probably limited to patients in which either has symptoms from the legs or have clinical findings which are suggestive of pulmonary embolism. A brief mention of the gold standard which we chose, because we chose this gold standard of 2 blinded physicians with reviewed all the journals for each of the most common diagnoses. We had made such diagnostic criteria, which whenever possible we tried to use international accepted guidelines. As example, if you could take for the diagnosis of heart failure, then we used what has been defined by European Society of Cardiologists as being enough to say that the patient has heart failure. Thus meaning that the patient must have symptoms of heart failure, they must have some sort of cardiac imaging which proves there's actually heart failure. So the reviewers didn't just use a gut feeling what these patients what was the cause of them being admitted. They had to use these predefined diagnostic criteria. So we believe that the strength of our gold standard is quite good, even though not all patients were scanned with CT and not all patients had echo performed. If we go on to the primary endpoints, which you showed before, with the correct diagnosis and correct treatment, I think I saw one of the blogs saying it was a bit odd using this total diagnostic accuracy as a primary endpoint. The reason why we chose this was also as an answer maybe to some of those who are more skeptical to point-of-care sonography. I know definitely many colleagues who would have said that if I scanned the patient, then they would say, well, we can already see that on the chest X-ray, or that was pretty obvious from the history take and so on. So what we wanted to do was to really show how big a difference sonography can make if you add it on to the other sort of diagnostics which are used, and not just to look at sonography isolated, so to speak. And the way that we found that it was going to be most pragmatic to show that was just to look at this total diagnostic accuracy. And well, it may be can be, of course, be discussed whether this is a good outcome or not, but I definitely think it shows the difference between standard diagnostics that we use and then what happens if you include sonography as a standard diagnostic test in among our standard diagnostic tests, so to speak. Then there was a question about, I can't remember the next slide, what we had there on that one, Vicky.
It was physicians reporting the change.
Yeah, sure.
Yeah.
Yeah, and was definitely, of course, if the sonography adds with something which is new information, that's of course important. And it can be questioned, these 41.8% with new information, what is that useful or not? I think most physicians, if they have some information about the heart, well, they would say that's new information, but if it doesn't really add any change in treatment, it can of course be discussed whether this actually means anything. But on the other hand, one can also say that the sonography is able to exclude many conditions. So maybe some physician could say, well, I suspect pneumothorax, but now it's ruled out, or maybe I doubt whether this patient had pulmonary edema, and we are also able to rule that out. So actually, as speaking as a clinician, I also find these 41.8% quite interesting, even though it doesn't add any real change to treatment. I think the next slide is about some of the additional diagnostics being ordered, and I also saw the blog in which it was pointed out that this sonography only led to more diagnostics being ordered. And as you also mentioned, Vicky, that this is only what happened within the first 4 hours after admission. So, of course, if your sonography really had a difference, then it also led to more diagnostics being ordered. But the impression we actually got from the study, and which you can also see in the results, is if you look at the entire hospital stay, then there's really no difference between the two groups in the number of diagnostics being ordered. So some patients would have left the ED, went to another department, and then at the department you actually discovered that the problem might be heart failure or the problem might be emphysema, so that the diagnostics were delayed and only ordered when later during the hospital stay. There's also a discussion in one blog that this initial diagnostics really doesn't add anything, but only leads to more invasive procedures and so on. And you can definitely say that about the diagnostic thoracentesis performed in the sonography group. But speaking as a physician who works in a respiratory medicine department, we have many patients in which emphysema or pulmonary effusion is not detected until late during the hospital stay. And those patients really are in need of initial right diagnosis and an early performed diagnostic thoracentesis. And so definitely in my opinion, it's important to get these patients correctly diagnosed initially while they're in the ED. And of course, sonography is an ideal means of doing this, as you are able to quickly visualize whether this patient has pleural effusion or not. Of course, it's a bit with the next slide with mortality as well, because I also saw some mentioning that increased diagnostics leads to increased mortality. I don't know how the mortality for patients admitted to the ED with respiratory symptoms is in the States, but in the overall mortality of a hospital stay in Denmark is around 7 to 9%. And if we look at the patients in our study, most of the patients who died were older patients which had a do not resuscitate order printed in the journal. So most of the deaths were actually expected death, and I think there was around 2% of the deaths which were unexpected, or in which some could say that this could have been prevented. So actually, it's only a few percent of the patients which had some diagnosis in which the death could have been prevented. So in such a small numbers, it is really difficult to show that there's a difference. You would need a much larger study, and of course the difference in these numbers are, you can't say there's any statistical significance. It's a bit the same if you look at the length of hospital stay, which definitely is relatively short in a Danish setting of only 3 days. So if you had to show that the length of the hospital stay went from 3 to 2 days, then you would really need a larger study, in my opinion. And most of these patients are elderly with relatively severe diagnosis as heart failure and pneumonia. In some patients, I think it would be quite difficult to shorten the length of stay of the hospital even further. Can't remember what then was the last slide here.
I have a question. So first of all, congrats. This is really nicely done, and we are huge believers in lung ultrasound. So it's always nice to see any kind of study showing that lung ultrasound can make a positive difference. We've tried looking similarly at how it influences what's already being done, and that's we think this is a nice strength of your study in that you're not just doing a standalone test outside of the clinical picture. So you're letting the physicians who are taking care of patients incorporate the findings into their decisions. And I'm kind of interested at what the interface is between you and the clinicians. There are a lot of different ways to do that. One way is to show them the pictures and let them interpret it. Another way is to show them, to interpret it for them. But it also depends somewhat on what your team knows about ultrasound. We've looked at this before, and we asked them, how much do you think is CHF? Oh, I think it's only 30%. Well, let me tell you, there's B-lines everywhere. Well, I don't know what a B-line is, so it's still 30%. So you need some incorporation of that. So can you talk a little bit about what you did with the findings and how you brought that to the team and what they would do with that?
It's definitely also a problem. We did a pilot study prior to the RCT in which we did a blinded sonography, and only the patients in which had some significant finding with a life-threatening condition, the findings were unblinded. And in those patients, it was also a problem that some physicians simply didn't believe the sonography findings. Many of our ED physicians are not very familiar with sonography. So we did a pragmatic solution in our study was to, after each sonography had been performed, we had a report sheet in which it was ticked out whether this patient was had pulmonary edema, possible pneumonia, heart failure, and so on. And then the physicians were shown the report from the sonography, and then they were informed that the sonography results indicated that this patient is suspected of having heart failure and pulmonary edema and so on. And then they were asked whether they would have any questions to the findings or the interpretations, and if they didn't have that, then that was that. So they weren't asked to interpret the image themselves because many of them simply wouldn't know that. And they weren't informed that there was many B-lines, or instead they were informed that there was interstitial syndrome, which is a common finding in pulmonary edema, so to speak. So there was some interpretation of the sonography findings for the physician, because otherwise they would simply have they wouldn't have know what to do with it.
And that's what we found also is that, I think many people are familiar with looking at cardiac echoes, and so that's a much easier thing to convince people, but some of the lung ultrasound stuff, you have to do a bit of interpretation for people, and so it's more of a challenge.
Definitely is. And if you look at what the final diagnosis are of these patients, many of them are COPD and pneumonia and so on. And of course, many of these patients do quite well. And most patients getting admitted in Denmark have been seen by a general practitioner before they go to hospital. So many patients with pneumonia have actually got antibiotics already at home. So, and as I told earlier, the mortality is quite low. The reason also why we chose this 4-hour limit is simply because our hospital guidelines set this as a cutoff. So it was a convenient place to also set our cutoff of when we wanted a correct diagnosis. The key issue here is if you want to establish a correct diagnosis, you can increase the proportion of patients correctly traced if you include sonography in the standard regime. So, it's, of course, if you want to wait for the next day for a correct diagnosis, go ahead. I know if I get admitted to the ED, what I wanted to do.
Yeah, but I think it is a good point in that I think as we think about next steps and looking at outcomes, because I think we're all being pushed, and Matt, you and I had an email conversation with some people about this too. We're being pushed to kind of make the diagnosis, make it earlier, initiate treatment earlier, but only use ultrasound if we can show some outcome difference. And I'm not sure that is going to be realistic.
Oh.
As you say, a lot of these patients are complicated, they have multiple comorbidities, and so one point of care test is not going to change mortality. And so I think it's a little bit unrealistic to expect that one test is going to, affect downstream this huge cascade of outcomes. However, I think it is really important to make that diagnosis early, because then you can go take care of the next patient. So there's some there is some value to that. It may not be in the individual, it's in a system-wide kind of approach.
If we were held to this standard in emergency medicine of no diagnostic test without showing an outcome difference for that specific test, then would we really order a CBC, a BMP, and chest x-rays for suspected pneumonia, or would we even order a fraction of what we normally order for that matter? I challenge you next shift to look at the several hundred orders that you put in and try to find a mortality difference for any of them in isolation. I mean, sure, there are a few like antibiotics and sepsis, but in general, our treatments, and especially diagnostics, work together as part of a package to deliver good care. Really not sure if there are any diagnostics that could be pulled out by themselves and shown to make a mortality difference. It's somewhat ridiculous to not use a test, though, that has obvious efficiency benefits just because there's not yet a proven mortality benefit. Just to drive home the point, though, if there are those of you out there who think we shouldn't use ultrasound or respiratory distress, I want to show you a graphic. We'll show you this graphic again later, but just let this sink in for a minute. And while it's sinking in, I think we're at a good stopping point. I'm worried your brain may be full, as we're well over our normal 20 minutes or so we try to stay under. We've got even more issues we want to discuss with the author, though. So next podcast, we're going to get into the question, did more ultrasound in this study lead to overtesting? And what the heck is the deal with the trend towards increased mortality in the ultrasound group? We'll tackle those questions and questions from the Twitterverse very soon. See you in a few days. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.